Good morning. Thank you for the kind invitation to be present during the second edition of this very interesting course. And I will proceed directly to the case. So this is a case of a 67-year-old male who comes at my consultation with chest pain at rest, and especially when exposed to mental stress. The patient is a professional musician, and he says very, very clearly that when he prepares to give concerts in public, he has chest pain during his preparation. A hypertensive patient, diabetic, dyslipidemic, who has quit smoking some years ago, and he has already had a stent at his right coronary artery back in 2023. At that time, we also evaluated an intermediate mid-LED lesion with FFR that was deemed to be non-significant with a value of 0.86. The patient had a repeat coronary angiogram beginning of 2024 because he had chest pain at rest. And the findings were identical to the images we had post-PCI, so we did not proceed to further treatment. He is well controlled for his hypertension, diabetes, and dyslipidemia with medication. And this is his ECG, which is not properly rotated, at rest, which is absolutely normal. Before proceeding to the cath lab, what we did is that we asked our echographists to do a dobutamine echo to see if he has ischemia, which was not the case. So no wall motion abnormalities during dobutamine echo, no changes of the electrocardiogram. However, the patient developed typical syndromes and dyspnea during the stress test. And according to our echographists, this was a case to be discussed whether it should be referred for a repeat, a third coronary angiogram. So let's just make a brief stop here. Would you justify planning a third angiogram here, or would you do otherwise?
That's a very good question. I think that we can have also the opinions of our discussion. So we start from the right end. Dr. Triantafyllou, would you like to give us your insight?
Yes, simply, I think that to clarify symptoms, we should proceed to a cath lab evaluation.
Anna?
I think maybe a CCTA should be also a good option for that reason. Maybe.
Mm-hmm.
Yeah. I wonder, when you did the FFR that was 0.86, if you'd had a CFR then, that might have been nice, and an IMR then, I think you'd be in a much better place because you probably would have known where this was going, if that makes sense. I think there's two ways to do this, isn't there? You can either go with empirical medications for, if you like, microvascular symptoms / vasospastic symptoms and see if he gets better, or you can take him back to the cath lab for definitive testing. And I think I don't necessarily feel strongly either way, but I guess this man has got a life that is really quite affected, and so he deserves to have an answer. So I think I probably would take him to the cath lab.
Yeah, I fully agree. What he doesn't need is just an angiogram, because we already done many, and so if we want to be invasive, then we have to give the patient the information he needs.
Maybe we can, if I can just add, I think there are 3 points which are important here. I think this is an interesting case because it will occur in all of our labs, and these patients get repeated angios, as Simone said. That I think would be the biggest problem. So the 3 points are, first, what would the new angio bring? So the patient has an RCA stent. So in-stent restenosis after a year can occur. So that could be in that territory. We did not see the dobutamine-induced ischemia, but we did have dobutamine-induced symptoms. So symptoms he has that he may as well have in-stent restenosis. So this would justify an angio. Second, if he does not have any stenosis, what is the medication he has? So in terms of anti-anginal medication, he has amlodipine. So there are no nitrates, if I could see correctly. Mm-hmm. There were no beta blockers, if I could see correctly. You can go back. Yeah, it's only amlodipine in terms of the anti-ischemic medication. So we have a lot of medications we can give to reduce the symptoms. So that's the second point. And the third point is, if we do agree that the next angio will be performed, I would agree with Simone. It has to be not only angio. So if there is no instantary stenosis, we need to make sure that there is no spasm and microvascular disease, of course. So I think all these 3 points are relevant. If you would ask me whether it will be according to the guidelines that we proceed to another angio, that's an interesting question. We will have a presentation about guidelines, but just before that, in the guidelines, now of course you have a class 1 to perform microphysiology for microvasculature and spasm. However, only after a trial of medication doesn't succeed, if my interpretation is correct, of course, of the guidelines, which means we would need to escalate the therapy in this patient, anti-anginal therapy, see how it goes, and if the symptoms do not abate, then go to the angio. That being said, we risk the instantary stenosis of RCA, because if we only treat it with anti-anginals, of course, that can progress further. So these are the dilemmas and open questions I would have.
So thank you for these comments. For these reasons and another one that I will explain in due time, we decided to call the patient back for a third time to the cath lab. And this is his dominant right coronary artery. You can appreciate a patent stent at the distal part of the artery and mild lesions at the proximal part of the artery. And this is his left system with moderate disease at the proximal and mid part of the LAD without any significant disease in the circ. The distality of the LAD seems quite okay. And this is the lesion where we had measured a year ago, and we had an FFR value of 0.86. So what we first did was to measure a non-hyperemic index, RFR, and this was non-pathologic with a value of 0.92. This corresponds to the prox LAD lesion, and we also measured an FFR with a value of 0.89, which is on the same ballpark with the measure we had a year ago, 86. So this question comes next. Is the case closed here? We have ruled out significant instant restenosis. The mid-LAD lesion seems to be stable over time. What would you do next?
Any ideas from the audience? Would you do any further testing in terms of physiology, in terms of maybe something else? Dr. Karamasis?
If we believe his symptoms, I think that we have to proceed by testing microvascular function and spasm. I don't see the reason why not to do it. He's already on the cath lab table. We have a pressure wire down. We have the right tools to measure microvascular function. We don't lose anything to do it. We can only help this patient if it is positive. Or even if it is negative, at least we give him a nudge.
Yeah? Is another opinion, maybe?
I would have considered stress MRI before this last angio.
Can you?
What would be the added value of stress MRI on top of the butamin echo?
I believe it could show the microvascular dysfunction and would have avoided the last angio. Because as probability, I wouldn't consider high probability for restenosis. We had a negative stress echo, so I would be almost convinced before the stress perfusion MRI that it's microvascular dysfunction, and I would try to prove it with the MRI.
This is a valid argument concerning microvascular dysfunction. However, with this test, functional stress MRI, we cannot test for spasm.
I consider that, but he's already on amlodipine, so I wouldn't believe it's a high probability for the spasm.
Okay.
Yes, this opinion, however, as you said, Panos, maybe we should have something on the table, because regarding the vasospasm with the cardiac MRI, this is a message we cannot really understand what's going on with any spasm effects in any patient. So, is there any other opinion from the panel? Would you save a cardiac MRI in this patient?
No, I have not. I do not think that it would give a definitive answer. The definitive answer will be now, with the added value of CFR and IMR. I would not check for spasm first.
Yeah, at the same time, he had symptoms after the administration of metoprolol, if I correctly understood.
His symptoms were resolved after
So I
metoprolol.
think that even if it's on amlodipine, it would be important to test for a spasm, since maybe it could be a spasm that is being caused by metoprolol. Yeah.
So an additional reason for us to call the patient to the cath lab was the fact that he's diabetic. So we wanted to check his IMR just to rule out diabetic microvasculopathy. So I'm going to show you two measures of IMR. This is the first one, and I warn you beforehand that this is badly done. Why is it badly done? Because the curves overlap. As you see, we inject boluses of saline at rest. These are the blue curves, and then we induce hyperemia, and we re-inject boluses of saline, and these are the curves in orange. Here we have played with the induction of hyperemia, and we wanted to see if intracoronary adenosine would be sufficient to provoke hyperemia of a relatively long duration in order to measure IMR, which is clearly not the case because all curves overlap and you have a false value of IMR of 41. And then we did a different thing. We provoked maximal hyperemia by injecting intracoronary papaverine. Papaverine is an agent that can cause maximal hyperemia for about 2 minutes, and this allows for a more accurate measurement of IMR. And here you can clearly see the separation of the orange and the red and the blue curves, and we have a calculated value of IMR of 14, which is clearly normal. So this diabetic patient does not have microvascular dysfunction. You also see an FFR which is 0.90, corresponding to what we had before of 0.89. So with this test, we have ruled out microvascular dysfunction, structural microvascular dysfunction with an IMR of 14. Would you do additional testing here?
Maybe, if I may, I think this is important. I mean, we are here because of intracoronary physiology and imaging, and I think the techniques are important to be understood into their details when we apply them. You know, just opening an imaging catheter or getting the wire down the vessel will not cure the patient. That might be satisfying for some people, but it's not good for the patient. So we need to understand what happened. So if you could go back, please, one of the other things, if you go back, so here the question is, how to perform bolus IMR to a sufficiently high quality. And Panos nicely pointed some of the things. The other thing is, if you look at the orange box, look at the values of the mean transit time. 0.43, 0.73, 0.63. They are widely spread. If you see the encirclement, the rectangle around them, which is in yellow, it means that the system tells you this might not be good enough. So in my practice, I never accept such a disparity of values. This can happen for various reasons. Number one, during some of the administrations of the saline, your guiding catheter gets out. So the saline doesn't get into the coronary, so you have a different things. Or what likely has happened here is that the hyperemia induction was insufficient and not stable. It was weaning off. So, of course, when you induced a more stable hyperemia in the next picture, you will see not only that the values are smaller, can you just show them, just so they see the difference? Look at how consistent they are. 19, 26, 27, and the system doesn't give you a warning sign. So that, I think, is an important technical point seen in this case. Now the question about the hyperemia. So you can do IV adenosine, which is widely recommended. We have a problem in our country, in our center, that IV adenosine is expensive. So I followed the ALST school, which gives papaverine, and we do give papaverine. However, I have to caution that giving papaverine has been associated, at least in our center, with some ventricular arrhythmias. So, to avoid ventricular arrhythmias, you have to be very careful not to mix contrast and papaverine. The way we do it, we get off the contrast bottle completely off the table. Instead of the contrast, we get the saline, so that in the system, we never have the contrast when we give papaverine. Nevertheless, we still did experience some arrhythmia. So the question is, can we move to intracoronary adenosine, which is what Panos showed, and use intracoronary adenosine? Now, the hyperemia with intracoronary adenosine, in my experience, is around 10 seconds in most of the cases, even when you give high doses. So I usually give 3 to 4 micrograms into the left coronary system, which is a high dose. So above 400, the question is whether it makes any more sense. So even then, it's 10 to 15 seconds. So you have to be very quick. And I will finish with really congratulations to you, because you can try with intracoronary. Sometimes it does succeed, and there is data produced by Javier Escanet, published just a few months ago, showing that this intracoronary adenosine can work, can produce consistent curves. You just need to do a quality check, like Panos did. So if you see the curves that you could see on the previous slide, do not accept that result. You need to change something. Either you take papaverine or IV adenosine. Now, I know that many advocates will be against intracoronary adenosine, but I have to admit that after Javier's study, I started doing it, and in some cases, you do see consistent measurements like with this.
I add something, Dehan, very well said. I think there is another option, Panos, and can you elaborate more on this? Why didn't you do with having these signals that the first test was not really reliable, to do another test of adenosine maybe a little bit later after it's weaning off? So you can use intravenous adenosine for the first, when you didn't get can you have the previous slide? When you have this also warning from the system. Another point is that the system is very, let's say, intuitive, and as Dehan said, it gives you the curves, and you understand that you have not done the good job, and also there's a warning sign. So maybe after the weaning off the adenosine, then you can do another trial with intravenous adenosine, not go directly to any intracoronary, let's say, test, papaverine. Because if, in our practice, sometimes we get this, and by better injection, better, let's say, engagement of the catheter, you can have better curves, or you can erase some of the, let's say, the 0.7. You can erase this and get another try, because this is what is supported by the system. This actually, I think there are people who have worked with the system. I think Dr. Hamilos has also worked with this, and Dr. Karamasis maybe. So I think this is a very good system that gives you the ability to use the adenosine intravenously and then go on with another test. So maybe have your opinion on that.
Just a short comment. We use sometimes regadenosine. I don't know if you have any experience with regadenosine, but it's.
I heard it's good. I don't have any experience, but I heard it's good.
It's intravenous. It lasts one minute and a half, and it's enough to have these nice images.
Because we talk a lot about the technique and the recordings, we have the recorded case, a case of bolus thermodilution, and you will see there that we have to replace some boluses. So keep this, and we'll see it live, not live, but recorded in a few minutes.
All right. Okay. Go on, please.
So after having excluded microvascular disease with a normal value of IMR, we proceeded to functional testing with acetylcholine. And you can already see that we have changed our catheter. This is an ABU, and this is the baseline angio before starting to increase gradually higher doses of acetylcholine. And this is the baseline 12-lead ECG, which is absolutely normal. So this is after having injected the small dose of 2 gamma of acetylcholine intracoronary. We don't really see any difference in the caliber of the vessel. The ECG does not change either. This is the 20 gamma dose of acetylcholine. You might think that something changes at the very, very distality of the vessel. However, the ECG stays the same. We proceed with 100 gamma of acetylcholine, and now you can really see that things are moving, are getting really constricted in the distality of the vessel, and the patient starts having pain. ECG does not move at all, and we take the decision to go to the highest level of 200 gammas of acetylcholine, where we clearly see a reduction in the caliber of the vessel, especially its distal part, which, according to our eyes, it's more than 90% of the baseline value. The patient still has symptoms, however, his ECG is not changing at all. And this is after the resolution of spasm after having injected 200 gammas of nitro intracoronary. So this is after nitro or baseline, and this is the image just before that. If it plays. So, to conclude, we have 2 out of the 3 criteria for the test being positive. The patient had symptoms. We had an important constriction of the lumen, more than 90%. However, the ECG did not change. Would you consider this test being positive?
Yes, I think we have the reduction of symptoms. We have estimation of visual estimation of rather severe stenosis, diffuse distal stenosis. So I think it demonstrates and reproduces the symptom of the patient during his mental stress.
Totally agree with Kostas.
I think this is lovely. I think this shows all of the problems with the definition. I think it's beautiful because you can't tell me there's one person in this room that doesn't believe that coronary vasospasm is causing this man's typical symptoms when he's stressed just before he goes to perform. So, but if we're going to go with guidance, we would suggest, well, no, it's not. But you have to be pragmatic, I think. The other thing I think that's really, really interesting, we tend to do our acetylcholine with the pressure wire still down. Number one, because we like a safety wire down. Clearly, it's different among different centres, so that our guide doesn't fall out, and that if we need to give nitrate quickly because the patient's got no flow down their left main, we can be more reliable at getting nitrate down quickly. But of course, the PD will drop precipitously here, and you'll see that in real time. And so you know if your spasm is coming, and you know when to take a picture because you just follow the PD. We also know when people get symptoms from PD from doing a number of other orbiter studies, and often you have to get the PD down to about 0.45, 0.50. Everyone will have a slightly different threshold because of collaterals and everything else. So I think the whole definition needs redefining, and I think we need a study to redefine it that is much more just straightforward. Because I think, for me, this is spasm 100%, but as you say, it doesn't fulfill the 3 criteria. And the reason why is I think if you measured flow simultaneously, I think the microcirculation here would be doing an amazing job, would vasodilate beautifully, and the flow actually would be fine, hence why the ECG doesn't change. So that's my take on what you've got here.
Yeah. And we could see that the microcirculation is doing fine by the IMR of 14 and CFR 3. So the microcirculation is able to increase the flow when needed. So that, I think, is the explanation why we do not see ischemia, but we still have symptoms. Yeah.
Yeah, we do the same, Panos. The case is excellent because actually what we started to do because of cases like that is to as Thomas said, to put the wire down, and then instead of doing angiograms at each step, what we do is just to check RFR at the end of the infusion of acetylcholine. So, for example, in this case, what you would have seen is a very, very low RFR probably, and then you check with the angiogram and everything.
Just one question regarding that. That's actually an interesting approach. So just so that everybody is on the same page. So you keep the wire down inside the vessel while you give acetylcholine. Yeah, exactly. Now my question is, what do you do with tortuous anatomy? Because sometimes in tortuous coronaries, the wire itself is causing the spasm. So would you in that case not put the wire if you see that it's a tortuous anatomy? For example, a very tortuous LAD, just the wire itself will induce spasm.
Yeah, that's
an exception, right? It's an exception.
That's a tricky one, but in general, also for safety reasons, because when they add, huge chest pain with occlusion of the LAD, they can start to move, for example, and you lose the catheter, and then that could be a big issue. Or if you have a dissection of the left main because of the patient chest pain and everything, if you're not, ready with the nitro to go in within a few seconds, then it's just a safer environment for us. And then on top of that, obviously, if you have a very tortuous anatomy, we may skip the wire part. But in general, in the normal cases, what we do is to have the wire and to check step up.
Makes sense, yeah.
Before having the question by Dr. Skalidis, can I ask you something briefly? From your opinion, also I want to know something. How often do you see like an important arrhythmia induced by acetylcholine? And did you have any case that you cannot really, you were a bit stressed about how you can deal with it? So in terms of safety, because in Greece there is this notion we do not do very easily this testing because of some restrictions. So we'd like your input on that.
If I may, I think this test has gotten really bad press because people often mix acetylcholine with ergonovin. These are two different animals. Ergonovin should not be used anymore. And this has been clearly shown that it can provoke late onset of spasm even after having administered nitrates in the arteries. Deaths have been reported when the patient was back at his bed. It's not ergonovin, it's acetylcholine. It has a very short half-life. You can frequently see bradycardias, right? And then the antagonist for this drug is atropine.
Just a small comment. We do not see here ECG changing despite symptoms. I think that has to do with how any given patient perceives pain. I mean, you have patients that you do the injection of the contrast and they feel it, and you have others that have ST segment elevation and do not feel great things. So I don't think that the ECG is the most important here. I think that the vasoconstriction and the symptoms are the most important.
Mm-hmm. So can I just make one more brief comment?
Question?
Yes, congratulations, Panos, for the case. Just a brief question. At the beginning, before you measure FFR flow, CFR, usually you are giving nitroglycerin. Does it affect the response to acetylcholine?
It can, but we wait on average 10 minutes before proceeding with acetylcholine testing. So most of the nitrates action has been weaned off. We don't give verapamil, however, through the radial sheath when we are considering doing this test because it has a prolonged mode of action.
Can I just make one more comment? The great thing about this case too is that you need to check with the patient, are these the symptoms that you get when you start to go to play the band or the music? Because if it's not, then again, you've just got some spasm like maybe all of us have if we put a big dose of acetylcholine down our coronaries. It's the same with PCI, isn't it? When you put the balloon up and you say, is this the pain you get when you exert yourself? You know, and we know from Orbiter, these will be the responders. And so I think that's a really helpful combination.
So a second question, is there microvascular spasm here?
Well, there was no slowing of the flow, so I would say rather not. I could not see the slowing of the TIMI flow.
For me, there is no answer here. We cannot really know.
What we do, trying to have an answer to your question, is after the last dosage. Obviously, in this case, the patient had chest pain, so you had to administer nitrates, and that's it. But if the patient has manageable symptoms and no huge vasoconstriction, what we do is to perform bolus thermodilution after the last step, just to measure an IMR that is actually not an IMR, but to see the mean transit time. Because if you have a real microvascular vasospasm, you would see a longer time, even than at rest. Mm-hmm. And so this can be an indirect way to diagnose a microvascular vasospasm if it exists. I mean.
So your wire is always a pressure wire that you keep?
Yeah, we keep it till the very end. After, if you don't have huge coronary vasospasm, we do 3 injections at the end of the last dosage of acetylcholine, and we see the mean transit time. If it's what happens usually is that if the test is negative, it's in the middle, so it's not huge hyperemia. It's not at the time you have at rest. It's like in the middle. If you have a far longer time than even at rest, then you may infer that you have some vasospasm in the microvascular system.
So this brings us to my last question, and this nicely sets the stage for my last slide. How should we treat this patient? He's already on amlodipine, on medical therapy for diabetes, dyslipidemia, and aspirin.
What do you do?
So we treated him with long-acting nitrates, patches of nitrates, based on this study, which to me is a very important study and sets the stage for personalized therapy in these cases. So this is a study published in 2022, where what they did was that they provoked spasm by acetylcholine. They re-challenged the patients while on the table with nitroglycerin, and they repeated the measurement a second time. And this is what you get. 3 take-home messages here. Most of the patients who come for acetylcholine challenge, they have microvascular spasm. Look on the left-hand side of the slide in blue. And when we treat these patients with nitroglycerin, most of them, 80% of them, do not relieve their spasm. They still stay with microvascular spasm. Only 20% of them has no spasm at the second test after having given nitrates. The second take-home message is that most cases of focal epicardial spasm or diffuse spasm are resolved with nitroglycerin. So to our eyes, nitroglycerin is a good therapy for people who have constriction of their vasculature, which is visible on angio images, and not so much for microvascular spasm. And this should be, for us, a standard test to be given to patients, meaning that we have to re-challenge them with nitroglycerin and repeat the test a few immediately after to see what is the response to them to better tailor therapy. So this also pertains to my question, is there microvascular spasm here as well? We don't know. We have these 3 different endotypes, but there is certainly a degree of overlap between endotypes. So to bring things to an end, what we prescribed the patient was a patch of nitrates.
Sorry, Panos. If your patient wasn't on calcium blocker, will you start again with nitroglycerin?
I would be inclined to start with a calcium channel blocker because of the better tolerability of the medication as opposed to patches of nitrates.
But would you give, in addition to amlodipine, if the symptoms persist, for example, would you give diltiazem? Because we have the EDIT CMD study, which is one of the only studies in this space that actually showed the efficacy of diltiazem very much if we provoke spasm on the testing. So I think that the relationship between diltiazem and spasm seems to be well confirmed. And you could theoretically give both channel blockers because they're different groups. So you could give amlodipine and diltiazem, and you could give high doses of diltiazem. So I think it's important to say this, that you can escalate therapy if the patients keep coming back. This is something we can do, and of course if they tolerate the medication.
I think this is a very, very pertinent comment, and this also opens the possibility of sequential drug testing with this re-challenge thing. It's not time-consuming to do the test again and again and again after having loaded the patient with X or Y drug.
Did the patients hate you, though?
He did not love me.
So thank you, Dr. Xaplanteris. Congratulations.